Hi guys, good evening. Can you all see me? Can you all hear me? Good evening, good evening. Can you all see me? Can you all hear me? Hi, good evening guys. Good evening, good evening. Yeah, we will start BLS series also soon. Today, we have a small pocket clinic series. We'll be discussing about real-time case scenarios and real-time case discussions. So that's the objective for this particular lecture. I am absolutely excited because it's about talking pure clinical sense and trying to discuss every single bit of it. Good evening, guys. Can we start? I've got something interesting for you. So today's case discussion is Yeah, today's case discussion will be on pain abdomen. So we'll see how are we going to deal with pain abdomen. Now this is something that you will see very often in your casualty, in your OPDs, wherever you're practicing. See, abdomen is a Pandora's box. Now when you talk about the pain abdomen, it can start at anywhere, it can go at anywhere, it can implicate something. There are a lot of differential diagnosis. You go mad when you get pain abdomen because you really don't know what exactly it is unless you have a clear-cut idea. Now what do you mean by this? Before I start our discussion, I would like to give you a small case scenario, right? Now, in this case scenario, I would like to show you a small video, right? And can you please take a class on gastric outlet obstruction and cleft lip and cleft palate? Absolutely, we can take it. Not at all a problem. Okay? Yeah. So let's look at this case. I'll just describe the case. We'll look at the video and then we'll discuss it that how are we going to deal with it. Now imagine you all are working with me. We are in a surgery department. I am your unit head. You are my residents and interns and we are going to deal the case and we'll see how well we can take the case across, right? Now, she's a 40-year-old female, all right? She is a top-notch corporate, right? She goes to office, works, comes back, and she loves eating avocado, like so much about her health conscious status. Now, look at her presentation and we will discuss. I want you to observe every single thing that is happening. She starts to eat. After eating, she starts developing the abdominal pain. Now she's having fever also. She's turning green. Oh my God. Now she becomes suddenly better, right? Again, next day she's having pain, again fever, and again she's turning green. Why is she becoming like a Hulk? What do you think is happening, right? So started off with pain abdomen, there's fever, and there is green, that is nothing but jaundice. So pain abdomen, fever, jaundice resolves and then comes back again, pain abdomen, fever, jaundice. What are we talking about? Any idea? Do you know what are we talking about? This is what we call as Charcot Triad. And I know you all know Charcot Triad is seen in cholangitis. Cholangitis is also going to present as pain abdomen. You'll be like, sir, what is this? Okay. If you think this is, I want you to see another case. Now, this is a 70 years old gentleman. He's sitting at his home, having his own coffee, tea, and suddenly this happens, right? Let's see what is happening to this guy. Now, this guy is sitting at home, having his coffee, and suddenly there's severe pain. It's so painful that he's calling his family members like, I want to go to hospital, I want to go to hospital, let's go, let's go, let's go, let's go. And they rush him to the hospital. At the hospital, he is lying down. The doctor is like, abdomen is absolutely soft. There's no signs and symptoms. There's no tenderness, no guarding, no rigidity, nothing. Absolutely fine. Patient looks absolutely good, right? In that context, what do you think he's having? pain out of proportion with minimal abdominal signs. These are the words that should click. Absolutely, Suraj. Just DM me across on the Instagram, we'll connect. Right? What do you think has gone wrong here? What do you think is happening? Again, another case of pain abdomen, but totally a different spectrum. The first case I told you about cholangitis, that is biliary pathology. This is acute mesenteric ischemia, pain out of proportion, severe abdominal pain with minimal abdominal signs. It is because of SMA artery occlusion. 70 years old guy, previous history of coronary artery disease, or let's say valvular heart disease, develops into emboli, then goes into superior mesenteric artery syndrome, or the superior mesenteric artery embolism, and resulting in acute mesenteric ischemia. Acute mesenteric ischemia presents to you with pain out of proportion. That means the amount of pain the patient is complaining and the symptoms do not correlate. This is one way of looking at it. Now, if you think you've seen enough, see this one. One more guy in his mid-40s, obese, and now while eating he develops pain abdomen, and there's something else exclusively here. Now, this is a guy who's eating a lot. After eating, he suddenly has pain, and that pain will now translate into hematemesis. Now, you're talking about pain abdomen with hematemesis. And which condition do you think it is? He's running to the hospital, right? He had food, he had vomitus. Post-vomiting, there is bleeding, hematemesis, pain abdomen, hematemesis, runs to the hospital. He is literally absolutely running to the hospital, right? See, I don't want you to guess the cases now. I just want you to see that what are the different scenarios a patient can come to you with pain abdomen, right? One, there could be a biliary pathology. Another one, there's a vascular pathology. This guy who is having vomitus, which is going to be with hematemesis, and then is going to hospital, that means he's absolutely hemodynamically stable. No, which condition will present to you? Think about it. Upper GI bleed. Upper GI bleed starts from peptic ulcer disease. You have gastric vascular and that is a gastric antral vascular ectasia. Mallory-Weiss tear is there. Bohr syndrome, but the patient will not be stable. There's so many differentials that you have, but this is a case of upper GI bleed. Now, if you think that you've seen enough, one more case. Now, this is a guy who has gone to London. Even after going to London, he is not satisfied. No, he still misses his vada pav and golgappa, and he is eating, right? Now, see what is going to happen. He is now gone to a street food, had the street food. After having a street food, he is now, every single time he eats the food, it hurts. And then there is hematemesis, food pain with hematemesis. And then there is perforation, peritonitis, abdominal distension, runs to the hospital. Street food, pain immediately after having food, associated with hematemesis, and then associates with perforation, peritonitis. What do you think the diagnosis is? What do you think the diagnosis is? Like, these are all basic cases that you will get in your hospital. It will happen again and again. But now, how do we diagnose it? That's another one. Now, you think pain abdomen are only seen in adults? No, you can have a kid with pain abdomen. Now, this is a 8 months old baby. Now, I want you to observe. This 8-month-old baby has a massive abdominal distension, extensive cry because of pain abdomen. Mother runs to the hospital midway while going, baby because absolutely fine, takes feed. Doctor says it's okay, let's look at the diaper. And when they look at the diaper, what did they find? They found red currant jelly stools, right? So again, a 10 months old baby with pain abdomen, which is intermittent, relieved, and takes feed. And when you check the diaper, there's red currant jelly stool. What do you think the answer is? What do you think the answer is? Did you get this scenario? What do you think the answer is? This is a classical case of intussusception, right? Now you can see that all these cases put together are pointing towards at one particular site that there is pain abdomen, pain abdomen, pain abdomen. How do you manage pain abdomen? Is everybody clear? Okay, great. So, what is the case number one? Quick feedback. Don't worry, we'll take you through the entire scenario. I'm just briefing you how a patient is going to come to you. Then I'll tell you how to work it up, how to diagnose, how to manage. That is all my problem. Your problem is just to look at the video and give me the answer. The first case scenario that we have, you have a 40-year-old female. You have a 40-year-old female who presents with pain abdomen, associated with fever, turns green, that is jaundice, gets better the next day, but again suddenly she starts getting pain abdomen again, there is fever, and then there is associated jaundice again. intermittent pain, fever, jaundice. Intermittent pain, look at where she's holding. She's holding in the epigastric in the right side. Two regions which are having. Very important that also I want you to evaluate that. What is this? Intermittent pain, intermittent fever, intermittent jaundice is a classical state of cholangitis, and this is your Charcot triad. Do not forget about it. Also, one more case that I did not show you before. Look at this guy. This guy is admitted in the hospital, right? He is again becoming green, that is jaundice, gets normal again, waxing and waning. There's weight loss is associated with it. Along with weight loss, he is not able to eat also. There's discomfort and constant pain, and there's severe itching, that is pruritus also. What do you think is this condition? Waxing and waning of jaundice associated with pain abdomen and severe pruritus. Severe pruritus. Now this is periampullary carcinoma. Again important, we'll talk about it. This guy, 70-year-old guy, right? Previous history of, let's say, valvular heart disease, has now presented to you with this symptom, right? Now presented with this symptom where he starts developing severe abdominal pain, that is sudden severe onset of abdominal pain, rushes to the hospital. The doctor takes a look at the abdomen. The abdomen looks absolutely soft. It is non-tender, no guarding, no rigidity. So pain out of proportion with minimal abdominal signs. Classical presentation for your acute mesenteric ischemia. Somebody is asking, sir, acute mesenteric ischemia, does it not occur in children also? It can occur in children when there is a midgut volvulus. It can happen there also. Okay? But usually it is associated with adults. Another case scenario that you have here, now this is a guy who is sitting, eating his own meal, suddenly starts developing pain. After pain, there is vomiting, that is going to be blood in vomitus, and then he runs it. Classical presentation of upper GI bleed, mostly associated with peptic ulcer disease. But when you look at this guy, now this is my favorite. I did not show you this case. Come on, quick. Let's look at. But I cannot take every single doubt that comes on a chat box, right? You have to be patient. We'll get to it. I've already answered your question. It is not necessary. It's not. See, when you talk about embolic occlusions, they're usually more common in adults, especially elderly patients. Okay, we've already said that. Clear? Chalo. Another case that you see, this is a guy who is in his mid-40s. Now see what is happening. This guy, on one hand there's a coffee, there's another hand there's a cigarette. He is on caffeine, on smoking, goes to a bar, sits, eats, drinks alcohol, and then starts developing severe abdominal pain. And then that burning sensation runs. If you have a burning sensation after smoking, right, then you have caffeine, that is smoking is there, coffee, caffeine is there, chocolate is there, alcohol is there, and then generates severe abdominal pain, which is not a burning sensation. The answer is going to be gastroesophageal reflux disease, right? So all these case scenarios are basically pointing towards that, pain abdomen can come in various forms. Because they can come in various forms, we should be absolutely be prepared. So let's try to understand that how would we decode our patients of pain abdomen, right? Now, anytime you see a patient of pain abdomen, the first thing, see, I'll talk about the entire performer, but just let's get used to it first, that how do we evaluate it? Now, when you look at the abdomen, this is the representation of the abdomen. The two landmarks that you have, the topmost is going to be your Ziffy sternum, which is here. Then you have the pubic symphysis, which is going to be present here, right? And the midway is going to be umbilicus. Umbilicus is in the equidistant. Ziffy sternum to umbilicus, umbilicus to pubic symphysis is going to be in the same regional distance that you have, right? Now, when you talk about the abdomen, I can divide the abdomen into 4 quadrants. If I take umbilicus as the center and I draw 2 lines crossing perpendicular to the umbilicus, I've now divided the entire abdomen into 4 quadrants, right? So what are these 4 quadrants of the abdomen? What are these 4 quadrants of the abdomen? This is your right upper quadrant, this is your left upper quadrant, this is your right lower quadrant, and this is your left lower quadrant. That is going to be left lower quadrant, right? Now, basically, it's an easier way to divide to see where exactly the pathologies are going to be localized. But then to get more specific component, we divide them into quadrants. We give it into smaller subsets. Now, those smaller subsets of the abdomen, the divisional status, again, we'll take this as the representation of the abdomen. Again, this is going to be the Ziphy sternum. This happens to be the pubic symphysis. This happens to be umbilicus, that is in the midline, right? So what we do is we'll draw two lines. The first line is going to be the mid-clavicular line, which is going to be on the right side. This is the right mid-clavicular line. This is the left mid-clavicular line. Another line which is going to pass from the superior border is from the transpyloric plane, which is here. And this is going to be the transtubercular plane. That is the anterior superior iliac spine. That is the bony prominence from it. We draw the line and we now divide the entire abdomen into 9 regions. This is the first region, this is the second one, this is the third one, this is the fourth region, this is the fifth region, this is the sixth one, this is the seventh, this is the eighth, and this is the ninth region, right? Now, if you label them across, it is going to be the first region is your right hypochondrium. It is the right hypochondrium. That is the first region. The second is going to be epigastric region. The second is the epigastric region. It is the epigastric region. The third one, if that is your right hypochondrium, this will become your left hypochondrium. This is going to be your left hypochondrium. This is going to be your left hypochondrium. Then you have the region number 4. The region number 4 is going to be right lumbar. Opposite to that is region number 6, that is going to be left lumbar. This is your left lumbar region. So you have the right lumbar and the left lumbar region. The fifth one is what we call it as the umbilical region. It is the umbilical region. The seventh one is what we call it as the right iliac fossa. It is the right iliac fossa. Eighth one is going to be hypogastrum, that is epigastrum, this will become hypogastrium. This is the hypogastrium. And the ninth one which is present is left iliac fossa. It is a left iliac fossa. This is your left iliac fossa, right? So these are all the divisional status that you have. Now, based upon where you have pain, you will have certain differential diagnosis. But even more simpler, no, if I have to keep it very simple, remember all your foregut derivatives. So I'll give you a shortcut to basically analyze this before we go down. See, when you talk about the entire gut divisional status, so all your foregut derivatives that you have, so you have the foregut, then you have the midgut, and then you have the hindgut. Now, all your foregut derivatives, that is all the way from the esophagus, the second part of the duodenum, the referred pain is going to be in the epigastrium. All your midgut derivatives, the midgut derivatives will be from the third part of the duodenum to the transverse two-third of the colon. This will be in the periumbilical region. The referred pain will be in the periumbilical region. The hindgut is going to be all the way till the proximal rectum. till the proximal rectum, and this is going to have a hypogastric pain. This will have a hypogastric pain. So based upon what is derived and where it is derived from, we have referred pain to the epigastric region, the periumbilical, and the hypogastric region. All your foregut derivatives will have referred pain to epigastric. What are your foregut derivatives? You're going to be esophagus, your stomach, your liver, your biliary system, your pancreas, your spleen. All that will have referred pain to your epigastric region. All your midgut derivatives will be periumbilical. All your hindgut derivatives is going to be hypogastric region. Now, if I have to specifically tell you, right, what are the pain or what are the conditions which are going to cause painful abdomen in each individual side, and this is going to be the most important slide that you have to remember. Now, what we'll do is we'll divide them into right hypochondriac region. We have the right hypochondriac. We have the right hypochondriac region. The top line, then you have epigastric region. Then you have the epigastric region, and then you have the left hypochondriac region. And then you have left hypochondriac region. Now, what are the conditions that can actually present you as pain in the right hypochondrium? The conditions are, number one, all biliary pathologies. Gallstones can produce pain in right hypochondrium. Cholangitis can present you pain in the right hypochondrium. Hepatitis. Liver pathologies like liver abscess. Right-sided cardiac failure. So, heart cardiac causes will cause right hypochondriac pain. Then you have right-sided lung pathology, because right hypochondriac pain, that is on the right hypochondriac region. In the epigastric region, they are usually associated with esophagitis. There's a esophagitis, peptic ulcer disease, pancreatitis, also associated with gastritis. All these will have epigastric pain. In the left hypochondrium, it is secondary to splenic abscess, that is spleen abscess. Secondary to splenic abscess, splenomegaly, basically splenic pathology, splenomegaly, and splenic rupture. With splenic rupture, right? So this is going to be the left hypochondriac region. Next comes the right lumbar. We had the right lumbar region, umbilical region, right lumbar region, umbilical region, and the left lumbar. And the left lumbar region. Now, in the right lumbar region, the causes for pain is usually ureteric colic and pyelonephritis. Ureteric colic and pyelonephritis. In the umbilical region, initially your appendicitis, then you have mesenteric lymphadenitis, mesenteric lymphadenitis, mesenteric lymphadenitis, Meckel's diverticulum, Meckel's diverticulum, and if there is any lymphoma associated pain, there is going to be umbilical pain. The left lumbar will have the same as right lumbar. It is going to be ureteric colic and pyelonephritis. And the pyelonephritis. Right. Now, The last line that we had is going to be right iliac fossa. We have the right iliac fossa, hypogastrium, right iliac fossa, hypogastrium, and the left iliac fossa. And the left iliac fossa. Now, in the right iliac fossa, it can be secondary to appendicitis, which is quite common. It is appendicitis. Then you have your inflammatory bowel disease like Crohn's disease, secondary to ovarian cyst in females, ectopic pregnancies, and hernia. Right, all this will be in right iliac fossa. Hypogastric pain is going to be seen in testicular torsion, urinary retention, testicular torsion, urinary retention, cystitis, and in gynecological, it is pregnancy-related causes. Example like abruptio, placenta, and all that. So, right, I'll just say gyna causes. The last one is in the left iliac fossa. You have the sigmoid colon. In the sigmoid colon, we are worried with diverticulitis, secondary to ulcerative colitis, ulcerative colitis, again ovarian cyst and ectopic pregnancies on the left side. Ovarian cyst, ectopic pregnancies, and hernia. Sometimes the pain that is associated with constipation will also be seen in left iliac fossa, right? So this is your entire playbook when you are evaluating the abdomen. This you should know, that what are the possible diagnoses if the pain is present in a specific region. Then based upon the character of the pain, how it is playing out, whether it is radiating, non-radiating, where did it start, where did it end, was it diffuse, was it localized, all that will play into consideration. Then you will have the abdominal examination. We'll see whether it is soft, tender, guarding, rigidity, all that is present or not, right? So this is the whole objective of looking at the abdominal status. Now, any patient who comes to you with the pain abdomen, we have a standard performer, right? Now, this is something that I'll be sharing with you. I want you to use it when you're going into your wards, you're carrying it in a casualty. If you're going to your surgery postings, keep this performer. This is going to guide you to get to a precise diagnosis. The first thing that you're going to do is to take patient details, right? Now, obviously, OPD number, date, that is there. Name is important, sex is important, age is more important, because there's certain pathologies in the abdomen which are specific in certain age group. For example, if I say female 40, right, in that age group, reproductively active age group, then we'll say it is and pain in the right upper abdomen or right hypochondriac region, it is cholecystitis, right? Now, in the same context, I have a 7 years old baby with pain in the right hypochondriac region. I'll not talk about cholecystitis or cholelithiasis. There it could be because of congenital choledochal cyst, right? So with the age, the diagnoses are going to vary very precisely. So fix to that. The rest of them is going to be address, occupation, and contact details is fine. Whenever a patient presents to you, always take down the principal complaints, that is chief complaints. Now, when I say what are the possible chief complaints in a patient of pain abdomen? So when you talk about the possible chief complaints, I'll just make a list of it. The possible chief complaints that a patient in the pain abdomen can give to you, right? So what are the complaints that can come across as chief complaints? Now, the first one is the pain itself. The second chief complaint could be vomiting. sensation of fullness, sensation of fullness after a meal, sensation of fullness after a meal, hematemesis, melena. Hematemesis is going to be blood in vomitus. Melena is black tarry stools, which is because the blood that has gone up will also mix up with these stools, right? Loss of appetite. It is loss of appetite, weight loss, alteration in bowel habits, alteration in bowel habits. It's more predominantly seen in colonic pathologies. Fever and swelling in the abdomen. So combination of these symptoms will actually point towards a diagnosis. So in the chief complaint itself, many a times you will have your diagnosis hidden, right? For example, if a patient says there is pain in the abdomen associated with vomiting, there is loss of appetite, right? There's loss of appetite, and then there's present pain is in the right iliac fossa. The answer is going to be appendicitis. Right now, see, any inflammatory disorder, we have rubor, callus, dollar tumor. So pain, abdomen with fever is going to be inflammatory disorder. As simple as that. So think in those lines. If you are in the right upper abdomen, what are the organs that you have? Liver and gallbladder. Left upper abdomen, it is going to be spleen. Dead in the center, esophagus and stomach. Slightly towards, in the midline, upper epigastric region, slightly towards the right side, it is your duodenal pain. You come laterally flanked, it is going to be a renal pain. You stay in the umbilical, it is a small bowel. It is going to be the left iliac fossa, sigmoid colon rectum. Right iliac fossa, it is going to be appendix and cecum. So you have a precise organ. In the hypogastric region, it is going to be bladder in association with testicular pain, radiating component, ovarian pain, uterine pain. All that is concentrated in the hypogastric region. Now, when you know all these organs, based upon these symptoms, you can pick it up, right? So chief complaints, you have to pick any of these are going to be precise. Now, then you talk about history of presenting illness. One second, it's misbehaved again. Now, in the history of presenting illness, the first and the foremost important is pain abdomen. You will ask the onset. When did it start? After the onset, you will see the onset and duration are two important aspects in the pain that you should know. That onset actually tells you that when did it start, and duration is how long the patient has been suffering from, right? Then the site where it has been presented initially, whether it is radiating or not, what is the character of the pain? Is it dull aching? Is it pricking? Is it radiating? Is it sharp? Is it gripping? So the character is very important. It in relation to food, whether the pain increases or decreases. Let's say if a patient complains about immediate food pain, that is as long as the patient eats, that means the pathology is either in the esophagus or the stomach. Patient complains about pain after 2 hours of consuming food, that means it is going to be in the duodenum. So in association with that, you have to pick it up, right? Okay. Now, aggravating and relieving factors, right? For example, patient says the pain gets better when he's leaning forward and gets worse on lying down supine. Classical for retroperitoneal component, right? Any retroperitoneal organs, when they get inflamed, when the patient bends forward, it feels better. When the patient lies down supine, it worsens. Classical example is going to be pancreatitis, right? Then on relieving, vomiting. So what is the character of the pain with respect to vomiting, defecation and micturition? If the pain relieves on vomiting, it is small bowel obstruction. If this pain relieves on defecating, it's a constipatory pain. If the pain relieves on micturating or aggravates on micturating, it can be cystitis, right? So these are the components which are going to be relieving and aggravating factor with respect to pain. Next, we'll see with respect to vomiting. In the vomiting, I'll always be very, precise about color, consistency and nature, right? Is it bilious, non-bilious? Is it projectile, non-projectile? How many episodes? What is the duration? What is the rate at which the vomit is occurring? All that is important. So duration, I've spoken. Relation to the food. If it is an immediate food-induced vomiting, then it is going to be gastric outlet obstruction. Is it projectile or is it effortless? Projectile vomitings are usually because of raised intracranial pressure, indicates of CNS pathology, otherwise it's going to gastric pathologies. The color encounter will tell you bilious, non-bilious. If it is green in color, that means this food has gone all the way to duodenum and then come back. If it is non-bilious, it is a gastric outlet obstruction. The food has not gone into duodenum itself, right? Presence of blood or not. Hematemesis, again, very, very important. It will tell you whether the patient is having an associated upper GI bleed or not. Is the presence of that particular disease or the pain is secondary to a hematemesis causing condition like peptic ulcer disease or not? So this is going to be with respect to vomiting. Next comes is your hematemesis. Now, in the hematemesis, again, duration, number of episodes, color, amount, and is it associated with melena or not? Melena is black tarry stools. See, minimum amount of blood required to cause melena is going to be 60 ml, right? So, based upon that, you know how much quantity of blood is lost. See, every patient of hematemesis, if it is consistent and progressive, patient will develop melena because whatever blood goes up via gravity, it will go down as well. The next factor is going to be with respect to jaundice. Now, whether the patient's pain abdomen is associated with jaundice or not. Same questions, duration, onset, progression. Is it associated with pruritus or not, telling you it is a severe form of jaundice or not. Again, same, loss of bile salts will result in clay-colored stools. Whether it is associated with fever or not, whether it is associated with biliary colic or not, will tell you about the biliary pathologies. Bowel habits, we'll talk about. Bowel habits are nothing but defecatory habits, basically. In the bowel habits, you will see what is the bowel habit like, bowel movement in association with melena, mucus secretion, whether it's tenesmus or not. Now, tenesmus is a desire to patient to pass stools but unable to pass stools, and that is what we describe as tenesmus, right? Classical for your rectosigmoid malignancies, remember that. Loss of appetite, when it's a significant weight loss is present or not. What is the definition of significant weight loss? When more than or equal to 10% of body weight is lost over a period of 180 days, which is undesired. An undesired weight loss of more than or equal to 10% over a period of 180 days, right, or 6 months is what we call a significant weight loss. Significant weight loss indicates of malignancy. Then you will see, is there any associated abdominal swellings are present or not. So we'll see whether the swelling is causing symptoms or not. For example, if there's an epigastric swelling, right, which is present in this region, the epigastric region, and patient is having vomiting, pain and all that. And when you palpate, you notice there's a nice swelling which is present, right? And it has occurred after an episode of pancreatitis. And that is most likely to be pseudocyst of pancreas. And that swelling appears after 6 weeks of pancreatitis. That duration is giving you some context to pick it up, right? So duration is important. Size, one first notice, that is initial, and then progression. Always look for urinary symptoms because they can be misperceived as pain abdomen. So loin pain, frequency, dysuria and hematuria is noticed. Past medical and surgical history. Remember, always ask for any previous abdominal surgeries or not, because the most common cause for intestinal obstruction is post-operative adhesions, and that adhesions can cause intermittent obstruction, and that intermittent obstruction will cause the pain, right? Personal history, you talk about diet, whether vegetarian, non-vegetarian, frequency and all that. Appetite is good, bad or decrease. Is there any addictions, like for example, smoking, drinking and any other substance abuse? Family history of malignancies, treatment history previously is on, allergic history, and then come to general examination. In the general examination, this is what you look at. This is the performer that we follow that is going to be built. Then you have obviously your PISL that we call it as, that is pallor, sinuses, clubbing, lymphadenopathy and edema to be evaluated along with that, right? This is on the examination findings. In the examination findings, you look for the basic pulse, blood pressure, respiratory rate and temperature, and then move to local examination. Every local examination will start with inspection first, followed by palpation. So in the inspection, we'll see what is the shape of the abdomen. Is there any contour differentiation or not? We'll see the status of umbilicus, whether it is normal, inverted, everted or deviated. You look for any previous scars, any striae are present, any dilated veins, again associated portal hypertension, respiratory movement, that is movement of the abdominal wall with the respiration, visible peristalsis. Now, if the peristalsis are visible, that means there's some sort of an obstruction. If they're moving from left to right, it is gastric peristalsis. If it is right to left, it is your colonic peristalsis. Then you look for visible pulsations and any visible swellings. Then you'll go with palpation. Remember, before you palpate, one basic thing that you should do is ask the permission of the patient, ask them to lie down supine, expose them well, and before you touch, rub your hands. Why do you want to rub your hands? You don't want to touch the patient with your cold hands. It will cause discomfort. So always ask for permission, ask them to lie down supine, expose them well, rub your hands to make them warm, and then touch the abdomen. That's a very important one. Once the palpation is done, then you go with percussion, and then at the end, auscultation. Percussion, you're basically looking for any shift in dullness. Is there any fluid collection? Is there any gaseous collection? Auscultation we basically do to hear for bowel sounds to evaluate for the same. Sorry. Now, once you're done with the palpation, last you write a provisional diagnosis, then you go with investigation, final diagnosis, and the plan of management. Now, this is going to be the performer for every case that we are going to discuss, right? So, in the pain abdomen, see, pain abdomen is not one topic, there are multiple topics. So, what I will do is, with every single series of pocket clinic, we'll talk and address about pain in each individual region. We'll start with the right hypochondriac, then we'll go to epigastric, then we go to left hypochondriac, and so on, so on, so on. We'll build the cases so that we'll be able to diagnose them better. Okay? So, this is the performer that we're going to follow for pain abdomen. So far, any questions? Quick feedback. But a negative history is basically to rule out. Patient will tell you there are some problem or some symptoms. There's something that he will not tell you, but you have to confirm it. For example, patient says, I have pain abdomen. Okay. And along with that, I'll say, is there any other problem? The patient says no. But in order to confirm, they'll ask negative histories. Is there history of vomiting? Answer says no. There's a negative history. Is there any relieving factor that is associated with it? The answer is no. In the same quarter, any previous surgery is done. All these counts in negative history, because when you create that negative history, you rule out all the obvious components. That's why I've given you this performer to go in this line so that you can rule out everything and then come to a conclusive diagnosis. But a chief complaint should be written only in one single line, not a paragraph. Complaints of pain abdomen since how many days? Complaints of vomiting since how many days and how many times? And complaints of hematemesis for how many times and how many days? Chief complaint should be as short as possible. In fact, the easiest way to remember the chief complaint is, why did the patient come to the hospital? You ask the patient the exact reason what brought him to the hospital is a chief complaint. Is it the vomiting? Is it the pain? Is it the anorexia? Is it the weakness? Or is it pain per se? Whatever has brought him to the hospital will be a chief complaint. As simple as that. Okay? Is everybody clear with the performer? Right? So every single time we revisit our cases, this is what is going to be our spectrum. So I'll be discussing each individual cases. We'll start with the right hypochondriac pain cases, then epigastric pain, then left hypochondriac, lumbar, umbilical, left lumbar, and so on. So altogether, we'll have 9 cases in the abdomen in the pocket clinic that we will evaluate, starting from the right upper all the way to the left iliac fossa. Okay? Clear? But a summary will be case specific. I'll tell you when we talk about it. All right? Chalo. So if you have no other questions, that's it for today. Next time in the pocket clinic, we'll see you with one case at a time in the abdominal series. Until then, thank you. Goodbye. Take care.